Good evening, all. Last time we have discussed about the vulva. So today we are going to discuss the British Gynecological Cancer Society guidelines for vulva. Okay, these are published in 15th May 2020. So today first we will discuss about vulval Pagets disease, and then we will discuss about the vulval carcinoma. So welcome to the class. We begin with our code Master MRCOG with concept oriented clarity. So this today's topic is vulval Pagets disease, and it can be asked in the EMQ. Okay, so vulva is important from SBA as well as EMQ point of view. Two SBAs and two EMQs. Surely it will come from this particular topic which we have covered. Okay, so what is vulval Pagets disease? Actually, it is a rare intraepithelial adenocarcinoma of vulva, may be non-invasive or invasive, and it represents around 1 to 2% of all vulval cancers. So normally, what type of carcinoma we get in vulva is a squamous cell carcinoma. But here in vulval Pagets disease, it is a intraepithelial adenocarcinoma. Okay, this is something you should remember. It's an intraepithelial adenocarcinoma of the vulva, that is the vulval Pagets disease, and accounting for around 1 to 2% of the all vulval cancers. There are two, three typical buzzwords in this particular Pagets disease. You remember those and you choose the option as a Pagets disease. We'll see that in subsequent slides. So what is the epidemiology? It is a rare condition. It typically affects the postmenopausal women. Exact incidence is uncertain due to overlapping terminology such as non-invasive vulval Pagets disease, invasive vulval Pagets disease, vulval adenocarcinoma, or vulval Pagets disease with underlying malignancy. These are different terminologies which have been used. Okay, what is its association and etiology? It may occur as a primary cutaneous adenocarcinoma or may be associated with underlying malignancy such as urological, colorectal, uterine, or breast malignancy. About 46% may have synchronous or metachronous cancers also. So what is the clinical presentation? Patient may be asymptomatic or may present with itching, burning, irritation. Classically, you will see erythematous plaque with white scaling. Typically, it is called as cake icing appearance. Okay, so this particular buzzword, if you get in the clinical presentation, then choose the option as a vulval Pagets disease. So patient may be asymptomatic, but in general, the presentation is with itching, burning, irritation, and on examination, you will find the erythematous plaque with white scaling. Okay, and you will have to differentiate this from other features such as psoriasis and all those features. You will have to differentiate, and this particular buzzword will help us. Cake icing appearance. It can appear as a nodular, plaque-like, or pigmented also. Then what is the investigation? The investigation of choice, always a biopsy. It is diagnostic. It assesses invasion and invasion depth also. And we have to screen for underlying malignancy and other investigations such as cystoscopy, colonoscopy, hysteroscopy, CT, breast examination. All these are important. Okay. Then histopathology, presence of large pale Paget cells within the epidermis. Often they are PAS positive and CK7 positive. Okay, so histopathology, again, these particular large pale, and these are the cells within the epidermis. So please remember these large pale Paget cells within the epidermis because it is intraepithelial adenocarcinoma. Okay, so large pale Paget, remember P for P, pale Paget cells in Pagets disease, and they are seen in the epidermis, and they are PAS positive and CK7 positive, mucin also positive. Okay, so treatment is obviously surgical excision plus lymphadenectomy if the invasion is more than 1 millimeter. So alternative therapies will be imiquimod mode. This cream effective in non-invasive disease, especially to avoid surgery. Radiotherapy and photodynamic therapy have limited evidence. Then recurrence, it is known for high recurrence, almost 60 to 70% chance of recurrence is there, even with clear surgical margins. So always we try for R0 resection. Okay, so no residual disease. That is what is our aim. So even if you have a clear surgical margin after excision, then also there is a high chance of recurrence. Further excision may not reduce recurrence risk, and imiquimod mode or watchful expectancy may be considered when invasion is excluded. So if there is no invasion, you may go ahead with either imiquimod mode or watchful expectancy also. Prognosis, invasive VPD carries worse prognosis. Non-invasive has got a good prognosis and survival, but there are chances of local recurrence also. follow-up, lifelong surveillance in specialist vulvar clinic is recommended due to higher chance of recurrence to the extent of 70% and risk of late invasive transformation. So this particular disease is known for high recurrence, 60 to 70% chance of recurrence, lifelong follow-up in the specialist vulvar clinic is. So you will remember few things about vulval Pagets disease. It is an intraepithelial adenocarcinoma of the vulva and associated with other underlying malignancy also. This cake icing appearance, and histopathologically you get large pale Paget cells and which are PAS positive, CK positive, mucin positive, surgical excision along with plus minus lymphadenectomy depending upon the individual. Okay, and high chances of recurrence, specialist vulvar clinic follow-up. Okay, so these are the typical things in this. Thank you.